Good afternoon and a very welcome to this ERKNet webinar. We currently have 27 computers logged in and probably many more people listening. My name is Francesco Emma and I'm speaking from my office in Rome. So before starting, as usual, let me remind you that your microphones are turned off. But during and after the webinar, you can send in your question through the application that is present on your screen. And then I will ask your question at the end of the presentation. The webinar will last approximately 30 minutes, and we will then have roughly 15 minutes available for questions. Our speaker today is Professor Justine Bacchetta from Lyon in France. Justine is a professor of pediatrics in Lyon. She specialized in pediatric nephrology, and her interest is in pediatric diseases of calcium and phosphate metabolism. After completing her research fellowship at UCLA, she moved back to Lyon, and she continued there her work on pediatric bone disease. Her focuses and interests are on bone and mineral disorders that are associated with chronic kidney disease, with pediatric chronic diseases, with rare inherited renal diseases, and on bone physiology during growth. She's currently the secretary of the French Society of Pediatric Nephrology and a board member of the CKD-MBD working group of the ESPN. She has published more than 100 publications in peer-reviewed journal, and he is the recipient of the René Habib Award from the International Pediatric Nephrology Association. The title of her talk today is CKD-MBD, Pathophysiology and Management. Justine?
Thank you so much, Francesco. So good afternoon, ladies and gentlemen. And indeed, it's my pleasure to discuss today pediatric CKD-MBD from pathophysiology to management. And just okay, so I have a problem with my slide. Okay, so just to give you an overview of pediatric CKD-MBD, and just to remind you that calcium and phosphate metabolism is completely modified by CKD, and we have like two ions, like phosphate and calcium, that are regulated by three different types of hormones. We have the 125 vitamin D that is mainly synthesized by the kidney, and then we have the parathyroid hormone that is synthesized by the parathyroid glands, and then we have the FGF23 clotho-interplay with a synthesis of FGF23 by osteocytes and a synthesis of clotho by the renal tubular cells. And during chronic kidney disease, we have some consequences on bone and vessels of this deregulation of the system, leading to chronic kidney disease, mineral and bone disorders. And there is a very complex interplay between bone and kidney, and this has been nicely reviewed by Susan Ott in Nature Reviews in Nephrology in 2013. And you can see that PTH is everywhere, and we have a very complex regulation of the system. And CKD-MBD indeed is a systemic disease with some biological signs such as hypocalcemia, hyperphosphatemia, hyperparathyroidism, and decreased 125D levels. And in the same time, you have an impact on bone with renal osteodystrophy, growth retardation, and resistance to growth hormone, but you have also vascular calcifications. And all these symptoms occur as soon as glomerular filtration rate falls below 60 mL per minute per 1.73 square meters. And the first challenge for pediatric nephrologists is to allow a good bone status and to allow our children to grow correctly. And this quote from Jaap Grootoff that was published a few years ago in Kidney International evaluated almost 250 young adults with end-stage renal disease beginning between the age of birth and 14 years. And they were born before 1979. So obviously obviously things have changed, but I think the philosophy is there. And you can see that in this cohort of young adults with early and stage renal disease, 62% of them displayed a significant growth retardation, and 37% of them displayed clinical manifestations of bone diseases, with almost 18% presenting and suffering from invalidating bone disease. So this is really our first challenge. And in fact, the fracture risk in children with CKD has been recently evaluated in the CKD cohort from North America and was published in the GISN in 2015. And in this cohort of more than 500 children with CKD at a median age at 11 years, 16% had a past of fracture. And the fracture risk was evaluated to be 2 to 3-fold higher than in general populations. And basically, the authors were able to find some risk factors for fractures, such as growth retardation, walking difficulties, and high PTH levels. But they also found a positive and a protective factor against fracture, that was the use of phosphate binders, and notably the use of calcium-based phosphate binders. And the cause of bone impairment in pediatric CKD are multifactorial, with growth failure, an impaired growth hormone and IGF-1 axis, an inadequate intake of calories and proteins leading to denutrition, muscle deficits, and obviously during puberty, delayed puberty and hypogonadism. But there are also some acidosis, inflammation, vitamin D deficiency, and hyperparathyroidism that will worsen bone quality and bone quantity. And last, the long-term use of corticosteroids is well known by all clinicians, but do not forget that many other drugs can induce bone toxicity. And you can see on that slide that the use of calcineurin inhibitors will increase the expression of RANK ligand, and RANK ligand is an activator of osteoclastic activity and thus an activator of bone resorption. But this is only one example. The use of mTOR inhibitors, at least in animal models, but also the use of anti-epileptic drugs, the use of anti-acid drugs, and the long-term use of heparin can modify bone quality. And this list is not exhaustive, so please remember that when you use some drugs, you can also induce some bone toxicity. And then just to show you that the control of acidosis, it's in all the guidelines, and we know that we should correct serum bicarbonate in our kids for growth, but it's also important for bone quality, because acidosis, and these are experimental data showing that in acidic condition, you increase osteoclastic differentiation and you increase osteoclastic resorption. And in the same time, you inhibit osteoblastic differentiation, so that the combination of these two results show that acidosis has deleterious effects on bone. And then our second challenge after bone quality is cardiovascular disease. And I'm pretty sure that you all know this slide from Foley that was published a long time ago now in the American Journal of Kidney Disease, showing the risk of cardiovascular mortality in the line in black in general population depending on age. And as expected, you can see that younger people have a decreased risk of mortality than the oldest people. But when you look at the white line corresponding to patients undergoing chronic dialysis, you can see that the cardiovascular risk is almost as high as in the oldest general population, so that the difference between general population and patients with CKD in terms of cardiovascular risk is of the utmost importance in the youngest patients. And another way of presenting things is this recent paper published by Ms. Femme in the GISN in 2012, showing that in the general population of subjects aged between 1 and 24 years, that cardiac causes of mortality cardiac causes explain only 3% of mortality in general populations, and in contrast, in hemodialysis patients and in PD patients, cardiac mortality is the main cause of death in these patients, but it's also important after transplantation because you can see that 22% of death after renal transplantation are explained by cardiovascular morbidity, and I think this is very important for our clinical practice. So one of the main questions is how to evaluate CKD-MBD in pediatrics. And one simple thing is to evaluate growth, and we all know growth charts, and I think this is of the utmost importance, and it's very basic, but if a child has a correct growth, you can imagine that CKD-MBD is correctly balanced. But you can also evaluate CKD-MBD using biomarkers, and you can find all of them in the guidelines: calcium, phosphate, PTH, 25D, and alkaline phosphatase. And there will be a talk at the ESPN next week specifically on this topic. In the same time, you can also use Dexa, dual X-ray absorptiometry, and its use is full of controversy, at least in pediatrics, and we will see during the poll in a few slides whether or not you perform Dexa in your own center. And again, there will be a discussion at the ESPN next week on this topic. You can also evaluate CKD-MBD using cardiovascular evaluation with, for example, ambulatory blood pressure monitoring and cardiac ultrasounds. And obviously, you also have a lot of research tools with biomarkers such as FGF23, sclerostin, or new bone biomarkers. You can also do some bone imaging with MRI, PQCT, HRPQCT, and ultrasounds. You can also obviously do bone biopsy, and again, I don't know whether bone biopsy should be a research tool or a clinical tool, but this will be also a discussion next week at the ESPN. And for cardiovascular evaluation, you may want to measure carotid intima media thickness or pulse wave velocity. So the first poll is the following, and I will leave you some time to vote. So in your pediatric center, do you perform Dexa scans in CKD children? So you can vote. Okay, so basically 73% of you do not perform Dexa scans routinely in the CKD children followed in your center. And I told you a few slides before that it's a controversy at the moment, and I will show you why if I just, yes, okay. So in daily practice, Dexa has some advantages. It's a gold standard for assessing bone mineral density, inducing a minor irradiation, and it's not expensive and it's easily available in all centers. And on top of that, you can also assess body composition that can be of interest in CKD. But we have also some limitations of Dexa. It's a bidimensional technique, and this is a major technical concern in pediatrics, with a systematic underestimation of bone mineral density in children with poor growth. And also, Dexa does not distinguish between cortical and trabecular bone. And for example, we know that hyperparathyroidism will have consequences on cortical bone, whereas corticosteroids will impair trabecular microarchitecture. So basically, you cannot distinguish between these two compartments. And in addition, you cannot evaluate geometry and microarchitecture with Dexa. But there has been some recent paper showing that Dexa was able to predict fracture risk in adults with CKD. So, in daily practice, the KDIGO in 2009 no longer recommended Dexa in adults with CKD. But with the new KDIGO 2017, it is now suggested that BMD could be tested to assess fracture risk if results with impact treatment decisions. And I think it's probably something for adults. For children, Dexa is no longer recommended since 2011, since the paper from Hôpital in pediatric nephrology. And there are some modulation of this recommendation with the International Society of Clinical Densitometry position in 2013, saying that maybe Dexa could be performed when the patient may benefit from interventions to decrease their elevated risk of a clinically significant fracture and when the results will influence that management. But I have to say that in Lyon, we do not perform Dexa in daily practice, and I'm really happy to see that 73% of you do not perform Dexa either. So, next question is, have you already performed at least one bone biopsy in the CKD children followed in your center? And I will give you some time to vote right now. Okay, so let me show you the results. It's like 100% of you have answered no. So you do not perform bone biopsy in routine in your center. And I have to say that we do exactly the same in Lyon with small nuance is that with very specific children with specific genetic diseases, we sometimes perform bone biopsy to try to understand the pathophysiology, but in daily practice we do not perform bone biopsy, and I think it's the same for you. But again, we can discuss that because bone biopsy is considered to be the gold standard, and you can do standard histomorphometry with the TMV classification, the TMV classification being the turnover, mineralization, and volume assessment for patients with CKD, and you can also do some fancy research on bone biopsies. And again, we have some limitations. We have some technical limitations with the procedure. Even though some people have recently shown that we can use a Yamshidi needle, you can see these blue needles that are smaller than the typical Meunier and Bordier needle. And the other problem is that we don't have many pathologists to interpret bone biopsies. And in 2009, there was a detailed list of indications for bone biopsies, and in the new KDIGO 2017, it says that in patients with CKD 3 to 5, it is reasonable to perform a bone biopsy if knowledge of the type of renal osteodystrophy will impact treatment decisions. And again, I think that it's not that frequent in pediatrics that we need a bone biopsy in routine. Or whether in Europe we have a EUROD initiative that is chaired by Peter Evenepoel, that is an adult nephrologist in Leuven, Belgium, and is part of the CKD-MBD working group of the ERA-EDTA, and they want to organize a European registry of bone biopsy in CKD. And it could be an opportunity for our European children with CKD to be involved in this initiative, but again, it will not be in routine practice. So, the clinical consequences of pediatric renal osteodystrophy globally, whatever the type of renal osteodystrophy, will be globally the same. And if you have an adynamic bone, what we can call a low PTH state, but again, PTH is not a good marker of the underlying osteodystrophy. But if you have adynamic bone, that is mainly due to vitamin D analogs and calcium treatment, you will see growth retardation, calcifications, and fractures. And in the same time, if you have osteitis fibrosa, that is a high, what we could call a high PTH state, you will also have growth retardation, calcifications, and impaired bone quality with an exponential increase of vascular calcifications. And I think that in the future, the use of bone imaging techniques that are less irradiative and non-invasive can be useful. And in Lyon, we are lucky enough to have HRPQ-CT, that is a high-resolution peripheral quantitative computed tomography that allow us to distinguish between the trabecular compartment, the cortical compartment with a voxel resolution of 82 micrometers, and you can see on the right of your slide the difference between on the top healthy teenager, a healthy control, and on the bottom of the slide the results we obtain in a teenager after renal transplantation, and you can easily see the cortical impairment and the trabecular microarchitecture that is completely destroyed in this patient. And in the US with Marie Leonard, they also have PQ-CT and HRPQ-CT. And these are the results of in a cohort of 156 CKD 2 to 3 children with high PTH levels in comparison to what we do in Europe. And you can see that in these patients, when PTH levels are above the targets of the KDIGO guidelines, you have a significant cortical impairment with a significant reduction in cortical density and an increased cortical porosity. And it was a transversal evaluation of this cohort, but they also followed this cohort for 1 year. And the predictors of cortical density at baseline were higher PTH levels, lower calcium levels, and lower 25D levels. And more importantly, they were able to show that cortical density at baseline was associated with an increased risk of fracture during the follow-up, meaning that it was the first time that a bone imaging technique was able to show and to predict the fracture risk in pediatric chronic kidney disease. And we did something modest in Lyon with only 32 CKD patients, but as you can see, these patients displayed lower PTH levels in comparison to the American patients, and we did not show any difference in terms of cortical porosity, cortical density, and biomechanical properties in comparison to healthy controls matched on age, gender, and tenure stage. And I think that we should remember that PTH levels depend on geography, and when we interpret results of clinical studies on pediatric renal osteodystrophy, we should really have this schema in mind. And in Europe, I would say that we are in the green zone. You have France, you have Germany, you have Poland, you have UK, you have the Netherlands with the lowest PTH levels in dialysis pediatric patients. And after that, you have a progressive increase of median PTH levels in these patients. And I think this is really important in daily practice because we don't take care of the same patients. And just to remind you that high PTH levels are associated with impaired longitudinal growth, with vascular calcifications, with anemia, with left ventricular hypertrophy, and with cardiovascular disease. And these are the results from the HiPPN registry involving more than 1,800 children in 87 centers from 31 countries, showing that probably the best best PTH target in dialysis should be between 100 and 200 picogram per ml. And this is always a debate between Europeans and Americans to know which is the best and the optimal PTH target in dialysis. And just to remind you that depending on the guidelines you use, you have some different targets. And we would say that with the European guidelines from 2006, so 120, 180 picogram per ml, with the IPPN data in mind, is probably a good target in dialysis patients. From the KDIGO 2009, I think there is one main point we should keep in mind, and it's recommended that therapeutic decisions are based on trends rather than a single laboratory value, taking into account all the markers available for CKD-MBD. And just to show you that your therapeutic management will be completely different depending on the blue line for PTH evolution or the red line depending on PTH evolution. And I think this is one of the most important points of the talk, to base therapeutic decisions on trends. Then there has been some new guidelines in 2017 from the KDIGO, and I already tell you that Dexa is recommended in adults, and I also told you that I think it's probably not so useful in children. And what is also a debate is whether we should give some calcium-based phosphate binders or not. And in adults, the KDIGO 2017 suggested to restrict the dose of calcium-based binders, and in children, it's reasonable to base the choice of phosphate-lowering treatments depending on serum calcium levels, meaning that we should give a minimum intake of calcium to these kids. And for clinical practice in children, I think the 2006 European guidelines are still of interest, and I will review them very briefly because it's already the end of the talk. Just to remind you that we need a clinical and biological and radiological follow-up, and then that we need to correct acidosis, that we really need to control phosphate. And this figure from Kuro really showed that the longevity across species is increased when phosphate levels are really low, and I really think that we should try to keep phosphate within the normal range in all our kids. First with a control of nutrition, then with a dialysis intensification, and then with the use of phosphate binders with calcium or with non-calcium binders, and then that we should avoid 25D deficiency, and you have guidelines published by the ESPN CKD-MBD working group last year to avoid hyperparathyroidism with the use of active vitamin D analogs and maybe with cinacalcet, because the calcimimetics has been approved in Europe last year for children in dialysis. And then if it's not possible to discuss parathyroidectomy, but it's exceptional in pediatrics. For growth hormone therapy, you have some guidelines that will hopefully come soon that are chaired by Dieter Hafner in Germany. And then you have some discussion of what to do in case of hypocalcemia. And then the last part of the talk is to discuss the balance between bone and vessels in CKD. And one main difference between adults and children is that in adults, the better the bone, the better the vessels. And in children, it's completely different. And there has been a paper published by a Polish team in pediatric nephrology in 2008 showing with Dexa that the better the bone, the worse the vessels in these children with CKD. And we had similar results in our 32 teenagers with pre-dialysis CKD. And then we showed that the greater the trabecular thickness and density, the greater the blood pressure, and notably the diastolic and the mean blood pressure. And I think this is really important in a growing skeleton to keep in mind that that we should give some calcium. So maybe we give too much calcium in our children in Lyon, but not giving enough calcium supplements may be deleterious for bone in pediatric CKD. And you can see on this slide a lot of rationale to say that we should give calcium, because by histomorphometry, you have a defective skeletal mineralization when calcium levels decrease, that with tibial PQCT, lower calcium levels independently are associated with progressive cortical deficits. And the recent data from CKD that I presented a couple of slides ago is that phosphate binder treatment is associated with a significant lower fracture risk, especially if it's a calcium-based binder that is used. So we have data that provide a strong rationale for giving calcium supplementation in pediatric CKD, and I think we should really be cautious when we read the KDICO 2017 guidelines. In children, we need to give a little bit of calcium, but obviously not too much, because we may also be deleterious for vessels. So the management of CKD-MBD is multifactorial: phosphate, vitamin D analogs, calcium, and calcimimetics. The use of native vitamin D therapy to prevent the secondary hyperparathyroidism has been well shown by Rukhsana Shroff a couple of years ago in pre-dialysis CKD. And just to remind you, these recent European guidelines saying that the target of vitamin D levels in pediatric CKD should be between 75 and 120 nanomoles per liter. And then a last slide to remind you that growth hormone therapy is obviously very important for correcting growth, but that growth hormone therapy also improves mineralization, whatever the type of the underlying osteodystrophy. And it was shown in patients from the US, in Los Angeles, but also from patients in Europe. And if you have low turnover or high turnover at baseline, growth hormone will help you to correct bone turnover. So in conclusion, which management for CKD-MBD in pediatrics in 2018? We should have a global management with denutrition, anemia, acidosis, but also a management focused on mineral metabolism, and a management targeting not only growth, but also bone. And the take-home message I would like to give you today is that CKD-MBD is a close interaction between bone and vessels. And in pediatrics, we have to face a growing skeleton. And the question of calcium supplementation remains open. Which exact threshold would become too much? And I really think that we should use ERKNet to organize international trials to try to answer this question. And on the long term, we have to improve bone quality and quantity, but also avoid vascular calcification and cardiovascular morbidity, and try to maintain quality of life, improve self-esteem, and integration, social and professional. And I would like to thank you all for your attention, and I will be happy to take questions.
Okay, thank you very much, Justine. This was extremely interesting and very clear. So please, I'm sure you have questions, send them in so that I can transfer your question to me. So let me start while I'm waiting here to receive questions. So when do you use calcium carbonate, Justine? Just to be very practical. And what is the threshold upon which you would not give calcium carbonate to a child that has high phosphate?
I think in Lyon, but again, you have seen our data, and maybe in the past we gave too much calcium, but we would use calcium carbonate as first line for hyperparathyroidism in case of hyperphosphatemia. And if we want to supplement the child, we will tell the parents to give calcium carbonate after meals and between meals. And if we want to decrease phosphate levels, we will tell parents to give calcium carbonate during meals to bind phosphate. This is the first thing. And second thing, I think the only situation when we wouldn't give calcium is obviously if we have low PTH levels and or high calcium levels.
Okay. Okay, so Rachel Davison is asking you, if you do not recommend bone biopsy, does this mean you base all your management decision on biochemistry alone?
Yes, I think it's not only biochemistry, but also what I try to tell you is that we also take a look to the growth chart. And I'm really convinced, but I completely agree that it's low evidence data, that if a child has a correct growth, it's probably that its CKD-MBD is quite controlled. I know that bone biopsy would be helpful, but let's face the reality. 100% of you do not perform bone biopsy in a clinical practice because we don't have the facility to perform it, and we don't have the facility to interpret it. So we have to use what we have, and I think clinical data and biochemical markers are quite useful. And the other thing that really interested me, I was expecting this 100% or so of answer for the bone biopsy. To be honest, I was not expecting that 75% of you do not perform Dexa either. So I think we all do biochemistry and clinical follow-up. I don't know whether I answer your question, but I completely agree. And I really, when I don't know what to do with a patient, for example, a patient with oxalosis or cystinosis, I will perform a bone biopsy. But in clinical routine, I think the indication of bone biopsy in pediatrics is exceptional.
Okay, I certainly agree with you, and I completely agree with you that if a child grows well, he's having an okay bone biopsy, okay bone metabolism. But there's one category of patients. Well, I'm waiting for other questions that are actually coming in right now. That I wanted to ask you is about the newborns with end-stage renal disease. So my personal experience is that these patients that are very, very small, that are a few months old, these are the very challenging patients. They tend to have very high PTH, and in order to control PTH, you need to give quite a big amount of vitamin D and calcium. And if you look at their bones, especially those that have been on end-stage renal disease since the very first days of life, in general, when they are 1 year old, they all have on X-ray low densities. So I found this a category of patients that is very challenging. Can you make a comment and tell you what you do?
Yeah, thank you, Francesco. Indeed, it's very challenging, but in the same time, I think we have an opportunity and a chance is that these patients, we can really control nutrition and we really know what we give them in terms of calcium and phosphate, first thing. Second thing, in our experience, we try always to prefer PD in versus EMO in these small patients. And in our experience, usually we have to increase calcium levels if we want to control PTH. And in these very young patients, it's sometimes we accept 2.8 or 2.9 millimole per liter of calcium levels to control PTH levels. Probably it's not good in the long term, but we are lucky enough in France not to have too long time on the waiting list. So maybe it's because of that we allow ourselves to increase calcium levels. But with that, usually we have a correct PTH control. There is also another thing I would like to stress out in these small patients with CACute. You may not be aware that patients with TCF2 HNF1 beta mutations can display a high PTH levels, because it has been shown that TCF2 HNF1 beta is controls PTH secretion, and thus these patients can present with severe hyperparathyroidism. And I have to say that we had one patient with severe hyperparathyroidism, and despite Cinacalcet high doses, it was completely impossible for us to control HPT. And the second thing I would like to say, in these very small patients, sometimes we have to take them in hemodialysis because people contraindicated, whatever the reason. And in that case, we perform 6 sessions a week, 5 to 6 sessions a week. And in that case, we usually have to face hypophosphatemia, and we have to give some phosphate supplementation during dialysis session, because we all discuss hyperphosphatemia and the risk of hypophosphatemia on bone. But one should not forget that hypophosphatemia is not good for mineralization either. And in that case, if you have to put a child on hemo 5 or 6 times a week, please correct phosphate levels.
Okay, so I think this is very interesting, and I agree with you. You need to have higher calcium levels to control your PTH in these patients. I just don't know whether we're doing the right thing. And the TCF2 actually comment was very interesting. And on the same line, I just received now a few questions. So Georgia Malakasiotti is asking you, and I'm reading her question, which is very much related to the answer you just gave. What would be your priority in managing those toddlers that are polyuric on dialysis and significantly low calcium level despite appreciable dose of active vitamin D analog? Ensuring dietetic calcium intake via calcium-containing phosphate binders and emphasizing on cholecalciferol supplements? Question marks. So these are polyuric toddlers that have low calcium levels despite you giving them vitamin D analogs.
Yeah, again, it's low evidence, but I would increase vitamin D analogs, and for vitamin D supplementation, cholecalciferol or ergocalciferol, I will try to target the 75-120 nanomoles per liter, but not more than 120 nanomole per liter, because it's been shown that you can increase mortality in older patients. But I would really increase calcium and active vitamin D analogs in these patients.
Okay, so Vincent Mboya is asking you, excluding Dexa and bone biopsy, what is the least number of biochemistry to identify CKD-MBD? So how do you make the diagnosis, basically?
Okay, I wish I had the answer. I think we should keep calcium within the normal range for age. We should keep phosphate within the normal range for age. And then we have 25D with the guideline 75-120 nanomoles per liter, PTH. And I discussed briefly the problems and the discussion with Europeans and Americans on the PTH targets. But basically, I would say that in pre-dialysis patients, PTH should be in the normal local range. And in dialysis, PTH should be between 100 and 200 picogram per mL. And then there are some new papers showing, and in the recommendation you have also the alkaline phosphatase, and there is a paper from Isidro Saluski showing the interest of combining PTH and alkaline phosphatase, and I think in the future we should evaluate that. But in fact, we have like some pretty simple biomarkers to identify CKD-MBD.
But Justine, the question was more, how do you make the diagnosis that you have?
Yeah, with PTH and alkaline phosphatase.
Okay. And then we have a last question, and this question comes from Priyanka Kanderwal, and the question is, what are the indications nowadays for performing parathyroidectomy in children?
Okay. I do not have personal experience of parathyroidectomy in children, and I think in Lyon we never perform parathyroidectomy in children for CKD-MBD, obviously. I think that now we have the Synacal set approved in Europe for children undergoing chronic dialysis. The indications are very scarce. But for example, these patients with HNF1 beta mutations, one Canadian team reported in during the dialysis conference, but I think they have not published it yet. They reported the parathyroidectomy in their kid with a good success. But I really think that before discussing parathyroidectomy, you should really correct phosphate, correct phosphate levels, correct nutrition, give phosphate binders, and when it's really difficult to be sure of the compliance of the kid, what we did maybe 5 or 6 times in Lyon during the last 10 years is like giving vitamin D analogs IV during the dialysis session, like high doses of IV alpha calcidol to try to decrease PTH for 1 or 2 months and really try to give a stop to these high PTH levels. And in our experience, it worked, but it's a limited experience.
Okay, well, I think this brings the seminar to an end. Thank you very much, and Justine, this was very interesting, and I think that we all learn a lot. And goodbye to everybody until the next webinar. Thank you very much. Goodbye.